trying to find out just exactly what was involved in a patient who has suffered sudden cardiac arrest is sometimes pretty difficult. So we have a paper coming up in JACC Imaging, and this is in the March 2015 issue. It is late gadolinium enhancement among survivors of sudden cardiac arrest. And I am with Dr. Raymond Kwong, who is MD and PH, who is the Director of Cardiac Magnetic Resonance Imaging at Brigham and Women's Hospital in Boston. This is a tough group of people. Sometimes you know what it is, sometimes you don't. So what did you do with this particular paper?
Yeah, so as you referred to, about half the patients who have cardiac arrest often after a detailed workup, including non-invasive and invasive testing, are still left unanswered about the diagnosis or also their subsequent risks. So we make an effort to look back at the patients who were referred to us for clinical reasons, patients who had a detailed workup, suffered a cardiac arrest, and had a detailed workup including echocardiography, ECG, and invasive angiography. And this is a cohort of patients who still did not have a clinical answer and were subsequently referred for cardiac MRI. So we found that in about 3/4 of patients, MRI combining the morphologic information of the left ventricle and also the contrast-enhanced methods, so-called LGE, in looking at scar and infiltration, were able to diagnose about or make reference to presence of myocardial substrates for arrhythmia in about 3/4 of patients. And also we found that most interestingly, the LGE, or the contrast-enhanced technique, actually provided a substantial information about whether there's presence or the extent of substrates that could have been the cause of arrhythmias.
Once you know what's there, is it easier to manage these patients? Does it give you ideas on what you can do?
Right, so definitely. And one thing that would be more obvious or easier to manage a patient is that we can actually delineate their diagnosis. In this paper, about a little less than half of the patients with the abnormal MRI turn out to have a unrecognized heart attack. There are also patients who have myocarditis or inflammation of the heart muscle that were detected. Once we have a better grasp of what etiology could be the underlying culprit,
then you know how to treat.
You have a better understanding.
You know how to treat heart attack, you know how to treat myocarditis.
Correct. And also you can have a better prediction of the natural outcome or what's going to happen to the patient, which is important for to educate the patients about their future risks.
So what's your takeaway from this? If you have a recommendation to others, what would it be after this paper?
I think this paper, again, is a relatively small paper and it's a retrospective look. The strength of it is that it truly represents a cohort of people, of patients who have gone through the usual full workup of clinical assessment, and MRI resulted in a gain of more understanding of the diagnosis and the myocardial substrates. But this paper, there are still many questions to be answered. For example, can we use MRI as a tool to guide our therapy or to streamline the risks to the point that we can say, even amongst these high-risk sudden cardiac death survivors, is there a subgroup of patients who are actually have a lower risk, and we can sort of streamline different kind of therapy. Currently, therapies in this group of patients are invariably insertion of a ICD, which is invasive and costly. But there are other potential therapies as well, medical therapies or ablation of ventricular arrhythmias in specialized centers. So can we sort of refine the therapeutic impact, therapy downstream using information from the MRI? I think that will be a very important question.
And this paper by Dr. Kwong and his associates happens to be in JACC Imaging, and it is the March 2015 issue for Cardiol Source World News. I'm Executive Editor Rick McGuire.